The broadcast is now starting. All attendees are in listen-only mode.
Hello, am I audible? Hmm. Is there any way you people can contact me or just tell me if I'm audible or not? Hmm. There is a chat window uh, on the right hand side. If you can reply to it, it would be great. Hmm. Okay, I think I should start. We have 68 people here, and I'm not sure if you can listen to me or not. Is there any way you guys can reply or something in the chat box या कुछ? Okay, so I'm going to begin my lecture on shock. So my name is Arunav, and I'll be taking a lecture on shock. So this would be a short lecture, and I would be explaining some basics to you. And after the lecture, you will need to read the same thing from the book again. So that is the point. Okay. Okay. So we're going to study the pathophysiology, the types of shock, hypovolemic shock, cardiogenic shock, and distributive shock. So the shock, second, yeah. So shock is the clinical syndrome that results from inadequate tissue perfusion. So basically, the clinical shock is usually accompanied by hypotension. Now, what is hypotension? Hypotension can be a mean arterial pressure of less than 60 mmHg or a systolic blood pressure of less than 90 mmHg. So this life-threatening clinical syndrome called shock is characterized by one, hypotension, that is an acute reduction of effective circulating blood volume, and second, hypoperfusion, that is an inadequate perfusion of cells and tissues. So basically it's nothing but a demand supply mismatch. Normally the oxygen delivery is more than oxygen consumption, but when the tissue is in shock, the demand is more than supply. So the oxygen consumption is more than the oxygen delivery, right? There are various clinical indicators of shock, and this is how you will recognize that the patient is in shock. So, of course, the first thing would be the patient would have reduced mean arterial pressure. The patient would have tachycardia, tachypnea. Most of the shocks have cool skin and extremities, altered mental status, and oliguria. We will go on each of them very soon. So I would like to touch upon some basics here because I'm not really sure तुम लोगों को कितना याद है because ये तो physiology में पढ़ते हैं. So basically cardiac output is nothing but heart rate into the stroke volume, right? Cardiac output can also be defined as the mean arterial pressure divided by the total peripheral resistance. This is the same formula we used to study in physics, that the flow is the change in pressure upon resistance. So here the cardiac output is equal to the mean arterial pressure divided by the total peripheral resistance. Okay. What is mean arterial pressure? So basically the mean arterial pressure is the diastolic blood pressure plus 1/3 of the pulse pressure, and in turn the pulse pressure in turn is the systolic blood pressure minus the diastolic blood pressure. So this can also be written as 2/3 of the diastolic blood pressure plus 1/3 of the systolic blood pressure. So very clearly, as you can see, the mean arterial pressure depends more on the diastolic blood pressure than the systolic blood pressure. Um, I think you guys know, like systolic blood pressure is the maximum pressure during the systole, and diastolic blood pressure is the minimum pressure recorded during the diastole. Now you guys would argue that why does our system has blood pressure even during diastole? So basically during diastole, the some amount of blood pressure is still there due to the systemic vascular resistance. So our body has systemic vascular resistance, and that makes a major part of the diastolic blood pressure. So the mean arterial pressure is nothing but the cardiac output into the systemic vascular resistance. This formula is nothing but this one. The cardiac output was mean arterial pressure upon total peripheral resistance. इसको उधर ले गए. So the mean arterial pressure is now cardiac output into systemic vascular resistance. Now we have already defined shock as a decrease of mean arterial pressure. So basically any decrease in pressure can be caused by either a decrease in the cardiac output or the systemic vascular resistance. It can be either of the both. So if the cardiac output is decreased, we will get to know by cool extremities and delayed capillary refill. While an increase of cardiac output will have warm extremities and bounding pulses. So a decrease of pressure could be due to a decrease of cardiac output, which can be made out by a cool extremities. And if there is a decreased blood pressure, that is if the patient is in shock, there is decreased blood pressure. Yet at the same time, there are signs of increased cardiac output. That can only mean that the hypotension must be due to a decreased systemic vascular resistance. Because for hypotension to occur, either the cardiac output will decrease or the systemic vascular resistance will decrease. So if there is shock, if there is less mean arterial pressure and cardiac output is raised, so the only thing left is that the hypotension must be due to the decreased systemic vascular resistance. This is classical of the distributive shock, also known as the septic shock. Okay, so now we will go on a clinical approach. So basically now we have a patient who has presented to us with shock, that is decreased mean arterial pressure. Okay, now you have to see the extremities. हाथ पैर उसके ठंडे हैं या गर्म है, as simple as that. So if the extremities are cold, that simply means that the patient has low cardiac output, right? So the patient has low cardiac output. Now there can be two things. Why is there a low cardiac output? Low cardiac output can be if the heart is not functioning properly, one. Second, the heart is functioning properly, but the heart is not having anything to pump out. As in, the heart has no blood to pump out any blood. That is our hypovolemic shock. So there can be two things. One, the heart is not functioning properly. The heart is full. The heart has blood to pump out, but the heart is not functioning properly. So that is cardiogenic shock. The second is the heart is functioning properly, but the heart is empty. There is no preload coming. There is no fluid. There is no blood coming to pump out, and that is the heart is empty. That is hypovolemic shock. So we started from the patient having shock, that is mean arterial pressure is very low. Now we see the patient has cold or warm extremities. If the patient has cold extremities, that means the cardiac output is low. Now this can be mean two things. The heart is not functioning, cardiogenic shock, or the heart is functioning but the heart is empty, that is hypovolemic shock, right? Now if the patient is having shock but he has warm extremities, this we have already discussed in the previous slide. If he has mean arterial pressure is low but cardiac output is high, that will simply mean that systemic vascular resistance is low. So in this type of shock where the mean arterial pressure is low but the peripheries are warm, that would simply mean that cardiac output is high, but due to decreased systemic vascular resistance, there is shock. And the classical example is septic shock. We'll be studying septic shock on a later while. And if you see shock ke baad cold extremities, that means low cardiac output. Now how to differentiate between cardiogenic shock and a hypovolemic shock? So here we see something called the jugular venous pressure. Now what is jugular venous pressure? Jugular venous pressure or JVP is simply the pressure in the jugular veins. So this is a very simplified diagram for you guys, wherein the blood is coming into the heart. It is coming into the heart, into the right atrium, right ventricle, and it is going outside the heart through the left ventricle. So this is something called preload, that is actually the volume of blood in the ventricles at the end of diastole. And after load is the resistance the left ventricle must overcome to circulate the blood. Fine. So this, I think this is too simplified. The heart does not actually look like this. There is lungs in between. Let's do it. Okay. So this is the right atrium. This is the right ventricle. We have something called pulmonary artery right here, goes into the lungs. Then we have pulmonary veins which go into the left atrium, right? So if suppose this patient has cardiogenic shock, the heart is not functioning properly. There is preload, there is blood coming into the heart, but the heart is not functioning properly. So there will be no output, there will be no output. So there will be back pressure here, right? So there will be back pressure from the right ventricle. This back pressure will go into the left atrium. This will go into the pulmonary vein, into the lungs. So this fluid will get, through back pressure, will get accumulated into the lungs. This results in fluid overload in the lungs. This can be recognized by auscultation, and when we auscultate such lungs, there will be something called crackles, creps can be heard on auscultation in case of fluid overload in the lungs, right? Now this back pressure will further go into the pulmonary artery, into the right ventricle, into the right atrium, into the jugular veins. So basically the jugular venous pressure, which is actually measuring the pressure of the right atrium. So that would be increased in case of cardiogenic shock. Why? Because the heart is not functioning. Back pressure, lungs में fluid overload, back pressure, और यहाँ पर increased JVP. So either again shock, cold extremities, and there is low cardiac output, right? This plus increased JVP and crackles or creps in the lungs simply means it's a cardiogenic shock. While on the other hand, if the JVP is decreased, that will mean the heart is empty. It's a hypovolemic shock. Okay. Okay, next. So the pathophysiology, I think you all know by now. So basically there is an effective circulatory blood volume is decreased. This will lead to a decreased venous return to the heart. This will decrease to less cardiac output, decreased blood flow, decreased supply of oxygen, and oxygen leading to shock. So basically the cardiogenic shock that I just talked about starts right here when the cardiac output is low. Why? Because the heart is not functioning. While hypovolemic septic shock will start from here. They will both decrease the effective circulatory blood volume. Okay, so now we come to the types of shock. So we will study a simple this thing table to study the types of shock. So I am going to tell you 4 types of shock: hypovolemic shock, cardiogenic shock, and basically neurogenic septic are both together called distributive shock. So these are neurogenic and septic shock, and the parameters we will be studying will be the pulse rate, the cardiac output, the systolic blood pressure, the peripheral vascular resistance, and the JVP. Okay, so in hypovolemic shock basically means that the body has a deficit of fluid, right? So there will be blood loss. This blood loss will in turn activate the sympathetic system. Sympathetic system will do 2 things. The sympathetic system, 1, will increase the heart rate, and second, it will lead to the vasoconstriction of the resistance vessels, vasoconstriction of arterioles or the resistance vessels. This will lead to peripheral vasoconstriction. Why do we need peripheral vasoconstriction? Because we need the blood to shunt from the peripheries to the vital organs, right? This will help to maintain the cardiac output and the blood pressure. So since the sympathetic system is constricting the peripheral arterioles, this will lead to increased peripheral vascular resistance. And this peripheral vascular resistance will in turn increase the diastolic blood pressure. At the starting, I told you diastolic blood pressure is nothing but dependent on the peripheral vascular resistance. So if there is an increase in peripheral vascular resistance, this will increase the diastolic blood pressure, right? So in hypovolemic shock, the pulse rate would be increased. Cardiac output will obviously be decreased, systolic blood pressure would be decreased, and the peripheral vascular resistance will increase. JVP will be decreased, right? Right. So the second type of shock is the cardiogenic shock. Cardiogenic shock, अभी तो हमने पढ़ा cardiogenic shock. Simply, it is the same as hypovolemic shock. The pulse rate would increase, the cardiac output will decrease because the heart is not functioning. Therefore, the systolic blood pressure will decrease. Peripheral vascular resistance will increase, but the difference is that the JVP would be increased in cardiogenic shock due to back pressure. While in the hypovolemic shock, the JVP would decrease. We just studied the same thing in this clinical approach, right? Okay. The cardiogenic shock, the pulse rate can also um, okay. In the cardiogenic shock, the pulse rate can also sometimes decrease. And this actually depends upon the etiology of the cardiogenic shock. Like if the cardiogenic shock is due to heart block, then that will lead to decreased pulse rate. Now we come to neurogenic shock. So basically, neurogenic shock, a simple example is the spinal cord transaction. So in spinal cord transaction, if the sympathetic system is gone, then what will happen? It is very simple. Sympathetic system is gone, so that will lead to a decreased heart rate, right? Second, this will also lead to decreased cardiac output. This will lead to decreased systemic blood pressure. Now, if the sympathetic system is gone, so first it will not increase the heart rate, so it will decrease the heart rate. Second, there will be no increase of vasoconstriction in the peripheries, so that will lead to vasodilatation. This vasodilatation will lead to less peripheral vascular resistance and warm extremities, and also resulting in pooling of blood in the peripheries. So pooling of blood in the periphery will result in warm extremities. Garam हाथ पैर होंगे, and peripheral vascularization is decreased, and GVP will also decrease. Why? Because there is peripheral pooling of the blood. So there is no venous return. So there is no blood coming into the right atrium. So that will result in less GVP. Right. So this is the only shock. Neurogenic shock is the only shock which has both bradycardia and hypotension. Bradycardia and hypotension. Okay. And septic shock is again this thing. So the primary mechanism of septic shock would be, as I told you, decreased peripheral vascular resistance. Okay, the cardiac output is increased, the pulse rate is increased. Then why is there less systolic blood pressure? Why? Because of decreased peripheral vascular resistance. Okay, we will discuss this later in detail. So hypovolemic shock is characterized by decreased circulating blood volume, which results in reduction of effective tissue perfusion. Okay, so this can be hemorrhagic or non-hemorrhagic. Hemorrhagic is basically it is due to blood loss, while non-hemorrhagic would be vomiting, diarrhea, dehydration, third space loss, or burns. Right. So hypovolemic shock can be further divided into 4 classes. The parameters which we will discuss is the percentage of blood volume lost, the pulse rate, the systolic blood pressure, the diastolic blood pressure, the pulse pressure, the respiratory rate, the urine output, the mental state of the patient, and the management. Okay. So in the class 1, the percentage of blood loss is 0 to 15%. That is around 400 to 500 cc. Isme everything remains within the normal limits, right? Example of this type of shock is blood donation. When we donate blood, approximately 400 to 500 cc of blood is taken from us, right? But we don't land up in shock. It is actually called the class 1 shock, where all the parameters are normal and the only thing they give us is oral fluids, right? Okay. Now class 2 shock. So the class 2 shock is the one which has a 15 to 30 percentage of blood volume loss, or 1 liter of blood volume loss, right? So basically what happens is the blood will be lost. This I already have told you. The blood will be lost. This will activate the sympathetic system. This will increase the heart rate. So the peripheral pulse rate will increase. There will be constriction of the peripheral arterioles. So there will be peripheral vasoconstriction. Again, shunting of blood into the vital organs, cold extremities. And okay, so this is very important. Class 2 hypovolemic shock has a normal systolic blood pressure. Why? Because of compensation. So there the sympathetic system is constricting the arterioles, causing peripheral vasoconstriction, right? So this will shunt the blood into the vital organs, and this helps maintain the cardiac output and the blood pressure. So the body till now, till class 2, is compensating and is able to maintain the systolic blood pressure, right? So in the class 2 shock, the pulse rate will increase, yes. The systolic blood pressure would be normal, it will be compensated, but the diastolic blood pressure would raise. Why will diastolic blood pressure raise? Due to increased peripheral vascular resistance. Why is peripheral vascular resistance increasing? Due to peripheral vasoconstriction, right? So the diastolic blood pressure will be decreased. The pulse pressure is the systolic blood pressure minus diastolic blood pressure. Systolic blood pressure is normal, diastolic blood pressure is increasing. So the pulse pressure is narrow. Respiratory rate would increase, urine output would start decreasing due to decreased perfusion to the kidneys. Mental state, the patient will be thirsty and anxious, and the management will be giving him IV crystalloids like normal saline or ringer lactate. So class 2 shock is a compensated phase of hypovolemic shock. Why? Because there is systolic blood pressure is normal. The only change we see is an increased pulse rate. Now we come to the class 3 shock. Class 3 shock is the T-compensated phase of the hypovolemic shock. Why? Because one, there will be 30 to 40% of blood loss. That will be amount to around 1 to 1.5 liters. Pulse rate will increase. Now since the blood loss is too much, it cannot be compensated. This will lead to decreased systolic blood pressure. Blood loss is too much. There is no blood to even cause peripheral pooling of blood. So the diastolic blood pressure will also decrease. Pulse pressure will remain narrow, respiratory rate will increase, urine output will decrease. Mental state is that the patient would be confused. Management would be IV crystalloids plus colloids. We can also add colloids in this. So class 3 shock is the decompensated phase of the hypovolemic shock. This is okay. Class 4 shock is when the blood volume loss is more than 40%. That is more than 2 liters. In this kind of a shock, the vitals are not recordable. Systolic blood pressure, we cannot record anything. It is too low. And there will be anuria, complete anuria. The patient would not be able to produce any urine and the patient would be in coma. So isme you have to stop the bleeding from where it is happening and you have to give massive blood transfusion to the patient. Right. So we have 4 classes of shock. Important thing to remember is that class 2 shock is a compensated phase. Isme the systolic blood pressure would remain normal and only the first change to happen is an increased pulse rate. While class 3 is a decompensated phase of the hypovolemic shock and this will cause an increase in systolic blood pressure. Okay, so I think hypovolemic shock is pretty easy, right? And okay, now we come to the cardiogenic shock. I think cardiogenic shock to sabko bahut achhe se aata hai ab. So we come to the same diagram again. The patient presents with shock, that is less mean arterial blood pressure. It could be due to cold extremities, हाथ पैर ठंडे हो गए या हाथ पैर गर्म हो गए. हाथ पैर जब ठंडे हैं, cold extremities there, that means low cardiac output. This could be due to 2 causes, cardiogenic shock and hypovolemic shock. So now what we are studying is the cardiogenic shock, right? So ये हो गया, the heart is not functioning, there will be black pressure, fluid will accumulate in the lungs, there will be creps on auscultation, fluid will again, there will be back pressure and GVP will increase, jugular venous pressure will increase. Okay, so this is a definition according to Harrison, which is basically, it is very simple. Cardiogenic shock is characterized by systemic hypoperfusion due to severe depression of the cardiac index. ठीक है, घबराना नहीं है. Cardiac index है. Cardiac index is nothing but cardiac output divided by the total body surface area. So this is indirectly cardiac output only, right? So severe depression of cardiac index that is less than 2.2 and sustained systolic arterial hypotension less than 90 mmHg. ये दोनों हमें पता ही है. ये दोनों हमें क्यों पता है? क्योंकि पेशेंट तो आए शॉक से था, सिस्टोलिक ब्लड प्रेशर तो कम ही था उसका, कार्डियक आउटपुट भी लो था, ये भी हमें पता है ना. सो ये दो चीजें तो होंगी, severe depression of cardiac index and sustained systolic arterial hypotension despite an elevated filling pressure. So this is the main thing that differentiates cardiogenic shock from hypovolemic shock, that there will be an elevated filling pressure. The JVP will be increased. There will be filling in the heart. There will be no exit from the heart, right? Now this filling pressure is measured by something called as pulmonary capillary wedge pressure, PCWP, that is more than 18 mmHg. Now what is pulmonary capillary wedge pressure? So basically pulmonary capillary wedge pressure is measured by something called as Swan-Ganz catheter. So basically a Swan-Ganz catheter is inserted into the femoral vein, which goes up from the IVC, it goes into the right atrium, the right ventricle, and then it goes into the pulmonary artery, right? This Swan-Ganz catheter, when it reaches the pulmonary artery, it is wedged into the branch of the pulmonary artery. Hence the name pulmonary capillary wedge pressure, right? This indirectly reflects the pressure of the left atrium. The catheter cannot go till the left atrium. It has to bypass the lungs for it. So this is a shortcut method. What we do is we wedge the branch of the pulmonary artery and we estimate the pressure of the left atrium, right? So in cardiogenic shock, the heart is not functioning. So there will be back pressure. The left atrium pressure will increase. This will lead to increased pulmonary capillary wedge pressure. So the definition is pretty simple now. Cardiogenic shock, systemic hypoperfusion. Why? Due to severe depression of cardiac index and sustained systolic arterial hypotension despite an elevated filling pressure. ठीक है, बहुत सिंपल है, डेफिनेशन याद हो गई. Next, what is this? So this is something called CVP monitoring. central venous pressure monitoring. This is not PC, this thing, pulmonary capillary wedge pressure. So basically, it's an indicator to determine the amount of fluid required in shock. Like the treatment of shock is fluids, right? So, but how much amount of fluids do we need to give? What the fluids we're giving, are they enough or not? We need an indicator. So the best indicator is the pulmonary capillary wedge pressure. The pulmonary capillary wedge pressure. But this is too invasive. Though the most commonly we use in our wards is CVP monitoring, central venous pressure monitoring. ठीक है, ऐसे करते हैं. Okay. So the clinical features of cardiogenic shock बहुत simple है, हम सबको आते हैं आप, ठीक है. There will be dyspnea. The patient will be breathless. Why? Because उसके lungs में पानी भरा हुआ है. There is fluid overload. The pulse is typically weak and rapid because the heart is not functioning. Systolic blood pressure is reduced. There is tachypnea. There is jugular venous distension. Rails, crackles, creps are audible. Auscultation करोगे, creps are audible in most of the patients, right? Chest X-ray में क्या मिलेगा? There will be typically pulmonary vascular congestion. Again, lungs में पानी भरा हुआ है. Pulmonary vascular congestion and pulmonary edema in the chest X-ray. अब हमें echo करवाना है. Echo क्यों करवाना है? Because we need to know the cause of the cardiogenic shock, right? What is not making the heart not, why is the heart not functioning? We'll find out by doing an echocardiogram, right? So there can be many etiologies of the cardiogenic shock. ठीक है, इसको टेबल को देख के बिल्कुल नहीं डरना है, बहुत सिंपल टेबल है, ठीक है, मोटा मोटा याद करना है. So cardiogenic shock etiologies, it could be an acute myocardial infarction, very simple, ठीक है. It could be arrhythmias, tachyarrhythmias or bradyarrhythmias, could be arrhythmias. It could be cardiomyopathy, could be Takasubu या फिर hypertrophic cardiomyopathies. It can be a severe valvular heart disease. It could be toxins, basically anything that is stopping the heart from functioning. ठीक है, so that will lead. ठीक है, so I am again bringing you back to this diagram because this is an amazing diagram. The patient is presenting with shock, हाथ पैर ठंडे हैं, low cardiac output है, GVP भी बढ़ा हुआ है, lungs में creps नहीं दे रहे हैं, the patient is in cardiogenic shock. What will you do? You will evaluate for myocardial ischemia. You will do things like echocardiogram, invasive vascular monitoring, and you will start the patient on inotropes. And you will try to reduce the afterload. Okay. So now we come to distributive shock. It is 9:45, so we have like just 10 minutes left. Okay, so we are on distributive shock. What is distributive shock? Again, this diagram. Patient presenting with shock, मतलब mean arterial pressure कम है. दो चीजें हो सकती हैं, हाथ पैर ठंडे हो सकते हैं, हाथ पैर गर्म हो सकते हैं. हाथ पैर ठंडे हैं, cold extremities है, मतलब cold low cardiac output है. दो चीजें हो सकती हैं. It could be hypovolemic shock, it could be cardiogenic shock. If the GVP is raised, it is cardiogenic shock. If the GVP is decreased, it is hypovolemic shock. Done. Now we come when the patient is come with shock but has warm extremities. He has bounding impulse, मतलब high cardiac output है. अगर mean arterial pressure low है लेकिन cardiac output high है तो mean arterial pressure low क्यों है? क्योंकि systemic vascular resistance low है, मतलब septic shock है. Distributive shock का most common type is septic shock, right? Okay, so ये सब हमें अब पहले से आता है. Condition of reduced oxygen delivery where the primary physiological disturbance is reduction in systemic vascular resistance. Systemic vascular resistance कम है इसमें. That is why there is decreased blood pressure. That is why this is distributive shock. This is unique. This type of shock is unique. Why? Because there is presence of compensatory increase of cardiac output. This is very unique. Cardiac output बढ़ रहा है, right? The impulses are bounding. The pulses are bounding. The extremities are warm, right? But the primary disturbance is decreased systemic vascular resistance. Now, the distributive shock includes septic shock, which is the most common type of distributive shock. Others can be pancreatitis, severe burns, anaphylactic shock, neurogenic shock, endocrine shock, and adrenal crisis. But the most common and we are interested is septic shock, right? So ये हमने पढ़ लिया था table. It's a summary of all the 4 kinds of shock, and now we are gonna छोटा सा पढ़ेंगे septic shock पे. Septic shock हमें पता है the main pathology is decreased systemic vascular resistance. Peripheral vascular resistance कम होगी. ठीक है, there will be peripheral pooling of blood. Peripheral pooling of blood होगा तो हार्ट में ब्लड ही नहीं जाएगा, जुगुलर वेनस प्रेशर कम हो जाएगा. हार्ट में ब्लड ही नहीं जा रहा तो सिस्टोलिक ब्लड प्रेशर कम है. पल्स रेट तो बढ़ा हुआ है. ठीक है, इट्स एन हाई कार्डियक आउटपुट कंडीशन. लेकिन ये क्या है? इन लेट stages of septic shock, the bacterial toxins result in myocardial depression. So this can also lead to less cardiac output in the late stages. But हमें ये याद करना है कि हाई कार्डियक आउटपुट कंडीशन होती है, ठीक है। सो दिस इज अ न्यू डेफिनेशन ऑफ सेप्टिक शॉक। सेप्टिक शॉक पता करने के लिए पहले पता होना चाहिए सेप्सिस क्या होता है, राइट। सो सेप्सिस इज बेसिकली अ लाइफ थ्रेटनिंग ऑर्गन डिसफंक्शन caused by a dysregulated host response to infection. There is infection and there is host. Infection host को हुआ and there is a dysregulated host response. This results in sepsis, right? So we define sepsis as infection plus a SOFA score of at least 2. There is something called a SOFA score. ठीक है, this is a big table which is nothing but SOFA score. SOFA is not the sofa you're currently sitting at, but this is the sequential sepsis related organ failure assessment score. This has various parameters and it has score, right? So sepsis is infection plus a SOFA score is equal or more than 2. This is sepsis, right? So okay, but ये टेबल बहुत लंबा चौड़ा है, ठीक है, हमसे नहीं हो पाएगा, तुमसे नहीं हो पाएगा। क्यों नहीं हो पाएगा? क्योंकि लिवर में बिलिरुबिन चाहिए, हमें रीनल क्रेट चाहिए, हमें कोएगुलेशन प्लेटलेट्स चाहिए। इसको हमें वी आर डिपेंडेंट ऑन लॉट ऑफ लैब प्रोफाइल्स, दिस टेक्स टाइम टू कम, राइट। इन द इमरजेंसी वी कांट वेट इतना। सो इसलिए वी हैव समथिंग कॉल्ड एज क्विक सोफा, वी हैव समथिंग कॉल्ड एज क्विक सोफा। Because the SOFA score requires multiple laboratory tests and may be costly to measure repeatedly, a quick SOFA was proposed as a clinical prompt to identify patients at high risk of sepsis outside the ICU. Patient emergency में वापस आया, you will apply quick SOFA. If quick SOFA suggests that patient might be in sepsis, you send the patient to ICU, right? Quick SOFA consists of 3 parameters. 1. Hypotension, systolic blood pressure less than 100. Second, altered mental status. Third, tachypnea, that is respiratory rate more than 22 per minute. If 2 or more than 2 are positive, it suggests a greater risk of poor outcome. It does not suggest the patient is in sepsis, but the patient is in high risk of sepsis. So we should admit the patient and probably send him to ICU, right? Okay, so sepsis बड़ा topic है and we don't have much time. Anyway, I'll be having a sepsis lecture on Saturday on the 9th of the May. So तब I will discuss sepsis and septic shock in detail. ठीक है, इसकी पैथोफिजियोलॉजी में मेन तो बस यही याद करना है कि हाइपोटेंशन हाइपोवेसोडाइलेटेशन होती है ड्यू टू इंक्रीज प्रोडक्शन ऑफ नाइट्रिक ऑक्साइड इन ब्लड वेसल्स। वेसोडाइलेटेशन हुआ, पेरिफेरल वैस्कुलर रेजिस्टेंस कम हुआ एंड ये सब कुछ कॉज कर रहा है, ठीक है। वी विल डिस्कस दिस इन डिटेल इन आवर नेक्स्ट क्लास। अभी के लिए बस ये याद रखो कि डिस्ट्रीब्यूटिव शॉक होता है, प्राइमरी फिजियोलॉजिकल डिस्टर्बेंस में सिस्टमिक वैस्कुलर रेजिस्टेंस कम होती है। मोस्ट कॉमन कॉज सेप्टिक शॉक। सेप्टिक शॉक में क्या क्या होता है तो समझ आ गया। सेप्टिक शॉक की डेफिनेशन, ठीक है। सेप्सिस की डेफिनेशन हमने पढ़ ली, इन्फेक्शन प्लस सोफा स्कोर ऑफ मोर देन 2। व्हाट इज सेप्टिक शॉक? नाउ सेप्टिक शॉक इज व्हेन देयर इज हाइपोटेंशन requiring vasopressor support to maintain a mean arterial pressure of more than 65 mmHg। मतलब हाइपोटेंशन इतना तगड़ा है कि वेसोप्रेशर सपोर्ट चाहिए टू मेंटेन मीन आर्टरियल प्रेशर ऑफ 65 mmHg एंड आल्सो लैक्टिक एसिड मोर देन 2 मिलीमोल्स पर लीटर रिफ्रैक्टिव टू फ्लूइड रिसब्स्टिटेशन, ठीक है। सो दिस इज द डेफिनेशन ऑफ सेप्टिक शॉक, ये याद करना पड़ेगा, ठीक है। सेप्सिस कैसे पहचानना है? सोफा स्कोर 2 और मोर देन 2। क्विक सोफा हो गया, ये हो गया, ठीक है। So by this we come to the end of a lecture, है ना। This table you have seen again and again because this is a wonderful table, ठीक है। Quickly इसको रिवाइज करेंगे, कुछ नहीं है। Patient आया with mean arterial pressure less than 65, ठीक है। Patient is in shock. What will you see? You will see the extremities. हाथ पैर ठंडे हैं या गर्म है? हाथ पैर ठंडे हैं। Extremities are cold, clammy. That means the patient has a low cardiac output. Patient has low cardiac output. Cardiac output low क्यों है patient का? Cardiac output low क्यों है? It could be the heart is not functioning. Heart is not functioning. There is enough blood. There is enough fluid. Heart is full, but there is cardiogenic shock, right? Low cardiac output है, but अगर heart empty है, there is no fluid, there is no venous return, there is nothing. This is hypovolemic shock. How will you differentiate? You will auscultate for crackles in the lungs. If present, that indicates fluid overload in the lungs. Increased JVP, ठीक है, दोनों बैक प्रेशर आएंगे, मतलब कार्डियोजेनिक शॉक है। क्या करोगे? विल इवैल्यूएट फॉर मायोकार्डियल इश्चीमिया, इको करोगे, एनोटोमोलर करोगे, ये सब करोगे, ठीक है। अगर हाइपोवोलेमिक शॉक है क्या करोगे? फ्लूइड स्टार्ट करोगे, ठीक है। इफ देयर इज नो इंप्रूवमेंट, व्हाट टू डू? देन नथिंग इज फिटिंग। इट कैन बी अड्रीनल क्राइसिस, राइट हार्ट सिंड्रोम, पेरिकार्डियल डिजीज। डोंट बॉदर, है ना। अभी हमें क्या करना है, कार्डियोजेनिक शॉक करना है, हाइपोवोलेमिक शॉक करना है, ठीक है। इफ शॉक है, प्रेशर बहुत कम है, मीन आर्टरी प्रेशर बहुत कम है, लेकिन हाथ पे गर्म पड़े हैं, ये कैसे हो गया? Why? Because there is increased high cardiac output. High cardiac output. क्यों है high cardiac output? In spite of decreased mean arterial pressure. Because systemic vascular resistance is low. Example: septic shock. Septic shock. You start antibiotics. Antibiotics. Okay. So by this we have come to the end of our lecture. Okay. I hope you have got the basic gist of it. ठीक है. This was not a complete lecture in the sense you have to go back today, read the sepsis chapter from Harrison. What I have done is I've made that process simpler for you, as in I've explained the basic cheese, basic terms. I'm pretty sure you'll not be scared by the heavy terms. You can डरना नहीं है, and just go ahead, read that chapter, and कुछ भी समझना you can come back on me. My next lecture is on Saturday 9th May on sepsis. You can ask any doubts there. I don't think यहाँ पर तो कोई doubt पूछ सकता है. This is completely a one-way dialogue. So, but you can contact me. My name is Arunav Garg. You can contact me anywhere. You can contact me on Facebook. You can message me on Facebook, and I'll be happy to reply to any queries. Thank you so much. Bye bye.